Okay, welcome back, everybody. We are headed into another super high yield talk with Dr. Linda Lee. She's the Associate Professor of Medicine at Harvard Medical School and the Medical Director of Endoscopy at Brigham and Women's Hospital. And she's here to discuss the state-of-the-art management of pancreaticobiliary disease, something I personally refer back to often in teaching and practicing in our hospital. So take it over, Dr. Lee. Thank you so much.
Oh, great. Thank you so much for that kind introduction. And I want to thank all the course directors, including Chris, Glenn, Adam, everyone else. Congratulations on another phenomenal course. And I really appreciate the invite to spend a little bit of time with you guys with one of my favorite topics. Here are my disclosures. So let's start off with a case. 36-year-old female who's 12 weeks postpartum with mild intermittent right upper quadrant pain since the third trimester, who now presents with severe right upper quadrant pain. She's afebrile. You see her transaminases are fairly high with a T-billy of 2.9 and alpha is not too bad. White count, lipase normal. Ultrasound shows multiple gallstones and 6 millimeter CBD with no intrahepatic ductal dilation. So, should the patient undergo an ERCP? Well, to answer, and then the next question is, in order to answer that question, we really need to answer what is the likelihood that the patient has a CBD stone, because that's certainly, why we would go in and do an ERCP. So to help us answer that, this is the updated ASGE guideline on determining the risk of somebody having a CBD stone. So what you see there, those with high risk of having a CBD stone obviously have either a stone seen on imaging, or have cholangitis, or have bilirubin over 4 plus dilated CBD. Definition of dilated being over 6 millimeter for those with a gallbladder and over 8 millimeter for those without a gallbladder. In that case, they estimated the risk of having a CBD stone as being over 50%, thereby justifying the risk of ERCP. And the recommendation goes straight away to ERCP. Those with none of the risk factors have very low risk, of course, having a CBD stone, and conservative management is appropriate. And then in the middle, you have that so-called intermediate category where the patients may have abnormal LFTs without meeting the criteria for high, and they may have dilated CBD, again, without necessarily meeting the criteria for high. And those patients have about a 10 to 50% risk of having CBD stones. So the question is what to do with those patients. And I'll get back to that in a second, but let's first talk about various imaging modalities and how accurate they are for finding CBD stone. You see their ultrasound is actually really bad. You might as well flip a coin to figure out if they have a CBD stone. CT is a little better, but of course, MRCP followed by endoscopic ultrasound are really the best tests, with ERCP being the gold standard. A note about MRCP is that you do not need to give gadolinium for this. So patients who have renal issues, other issues with gadolinium can certainly have an MRCP. And you see there below the left image with the arrow pointing to a filling defect representative of a stone on MRCP. The middle image is a fluoroscopy cholangiogram showing very comparable image with a filling defect in the distal CBD, that white round thing representing a stone. And then on the right side is representative EUS image showing the white two stones there casting a shadow in the bile duct. So for patients with intermediate risk of having CBD stone, instead of going straight away to ERCP, they should either have endoscopic ultrasound, MRCP, or laparoscopic cholecystectomy with intraoperative cholangiogram. Which one you elect to do just honestly depends upon your institution and what is most readily available. For example, at the Brigham, there are very few surgeons who do intraop cholangiogram. So that is almost never done at the Brigham compared to, I know, other hospitals where they do that fairly routinely. Now, the reason we do EUS and MRCP in intermediate risk patients is because, of course, they're safer than ERCP. Neither of them have risk of pancreatitis. And about half of more invasive procedures could be avoided by doing EUS. Now, there are limitations to MRCP that I do want to point out. It has lower sensitivity for small stones that are less than 6 millimeter in size. And also up to 20% of the time, the intrasphincteric portion, the very distal bile duct, is not well seen on MRCP. A word about labs and obstruction from CBD stones. The degree of elevation of bilirubin usually parallels the degree or correlates with the degree of obstruction. Bilirubin is rarely very high, with some exceptions, of course, in patients who are cirrhotic or have renal issues. Transaminases, on the other hand, can present in the thousands. So this is one of the several things on the differential diagnosis for transaminases in the thousands. Back to our case, 36-year-old female with a right upper quadrant pain, total bili is 2.9. She has gallstones, her CBD is 6 millimeter with no intrahepatic biliary duct dilation on ultrasound. So she is intermediate risk for CBD stone. So the best next step is either EUS or MRCP. And MRCP is what was done in her, showed the gallstones again, CBD of 8 millimeter, but no choledochal lithiasis. So we elected conservative management, but she continued to have intermittent right upper quadrant pain after eating. And then over the next couple of days, her bilirubin actually rose to a peak of 6.1, even though, as you can see there, the other LFTs, in particular transaminases, had come down. Her alk phos had gone up just a little. So at this point, we said, well, despite the MRCP, there must be something going on. So we did EUS. And what you can see there in the lower left image, the round thing at about 6 o'clock is the bile duct. And you can see kind of faint, bright things in there. That's sludge in there. And the lower right image with that kind of weird, thin, long thing is her bile duct with, again, some sludge in there. So we went on to do ERCP. This is just a pictorial of what happens with ERCP. We use a so-called side viewing scope. In the lower right there, you see what we mean by that. The endoscopic optics are mounted at a 90-degree angle instead of being straight at the tip of the scope. And this is so we can see the ampulla easily, as you can see from the cartoon. And the goal is to get into the bile duct where you see that green catheter in there, and not the pancreatic duct in this case. This is a quick video showing you what we do during ERCP for stones. So you actually can see a little bit of that yellow stone peeking out from the ampulla there. And this is an example of a sphincteratome with a wire through it. And we're advancing the wire into the bile duct. You'll see some bile coming out now. And by the way, the pancreatic duct orifice is down below. It shares the same opening here. So that's why we can get post-ERCP pancreatitis. And now this is sphincterotomy. This is the cutting wire, and we're stepping on a cautery pedal. And you can see how we are cutting the biliary sphincter to completely open it so that we can then remove the stone from the bile duct. And that's a really beautiful sphincterotomy, lots of bile pouring out now. And then you'll see, here's an example of balloon. And we literally just advance this balloon above the stone. I'm not showing you fluoroscopy, but we're doing this under fluoro view so we can see the balloon catheter going up. We blow the balloon up above the stone and pull down, and there you see the cholesterol stone coming out. Now, the overall morbidity of ERCP is about 7% with a very small mortality rate. And as we all know, post-ERCP pancreatitis is the most feared and common complication, followed by bleeding, cholangitis, retroperitoneal perforation, and other, which mainly includes the MDRO infection. Couple of points here. Do not check amylase lipase post-ERCP routinely because oftentimes they will be high. Does not mean the patient has pancreatitis. Most people routinely give rectal indocin pre-peri procedural to try to reduce the risk of post-ERCP pancreatitis. After a sphincterotomy, which is actually a high risk for bleeding procedure, Ideally, anticoagulants, DOACs are held for at least 3 days and antiplatelet agent for at least 7 days. But of course, this needs to be tempered by the particular patient and whether they need to go back on these medications because they're at high risk for a thrombotic event. All right, so now we've done the ERCP. Now what? Well, every patient should have a cholecystectomy unless it is contraindicated. And the ESGE, which is the European Society for GI Endoscopy, recommends cholecystectomy within 2 weeks of ERCP. And the reason for these recommendations is that up to 40% of patients develop recurrent biliary symptoms after ERCP. This can be biliary colic, gallstone pancreatitis, cholecystitis, etc. And usually this occurs a median of 3 months after the ERCP. All right, let's move on to another case. This is case 2, a 79-year-old male with coronary artery disease, diabetes, end-stage renal disease on hemodialysis who was admitted with nausea, vomiting, atypical chest discomfort, and shortness of breath. No abdominal pain. The patient's daughter is a physician and noted that his mental status was far from baseline. Upon admission, he's afebrile, a little tachy, and a little hypertensive. He's alert and oriented ×1. His transaminases are just mildly elevated. His T-Billy, though, is 5.4 with an alk phos of 355. White count a little elevated, 11.8. Because of his shortness of breath, chest discomfort, he gets a chest CT, which is negative for PE, shows trace right pleural effusion. And he also gets an abdominal CT. And this shows diffuse biliary dilation up to 24 millimeter, and he is status post cholecystectomy. So the question here is, what is the likely diagnosis? Well, a little atypical, but likely cholangitis. And here we see Charcot's triad that I think we all know about, which is only present in a minority of patients with cholangitis. It equals right upper quadrant pain, fever, and jaundice. And you notice in this patient, he only had jaundice. Reynolds pentad is you add on change in mental status and hypotension to Charcot's triad. The Tokyo guidelines are better, and they include presence of fever or elevated depressed white count, abnormal LFTs, and some type of abnormal imaging, and more sensitive certainly than Charcot's triad for diagnosing cholangitis. And here you can do this online, and I just put in the data from my patient here, and it spits back that definite for cholangitis. Now you can continue on though. So I added on the neurologic dysfunction because of his mental status issue and his Billy's over 5, age over 75. And note here, it states he has severe acute cholangitis. So management of cholangitis is, first of all, resuscitation. It's not first ERCP. It's just like dealing with GI bleed. It is not first scope. It is first resuscitation with fluids, IV antibiotics. 80% of patients respond to this, although eventually biliary drainage is necessary. The times when you should think about percutaneous drain is if the patients had a history of failed ERCP, they have post-surgical anatomy. That can be very challenging for us to navigate or impossible to get to the bile duct, and or if the patient's unstable and ERCP is not readily available. In terms of the timing of ERCP, for patients with mild cholangitis, meaning they respond to antibiotics, it can be elective. For moderate, those who are not responding to antibiotics, so maybe they're continuing to have fevers, but stable, should be done within 72 hours. And then the severe patients, so for example, my patient, they should be done within 24 hours. Notice within 24 hours and not within an hour or two. And if you don't have ERCP capability, these patients really need to be transferred ASAP to somewhere where they can do ERCP. So back to my patient. He was started on IV vancomycin, piperacillin, tazobactam, and he grew out 4 out of 4 blood cultures positive for gram-negative rods fairly quickly. So we ended up doing an urgent ERCP in the afternoon, and the bottom left image shows pus coming out of his bile duct after we did the sphincterotomy. Middle image shows more pus-laden bile, and then on the right lower you see cholesterol-appearing stones that we're pulling out. All right, so let's move on to another case of a 53-year-old obese female who's admitted with severe epigastric pain that began last night. She is afebrile, amylase lipase are very high, ALT, transaminases are a little bit elevated with a T-billy of 2, alk phos normal, white count 10. What is the likely diagnosis here? Well, acute pancreatitis, right, with the incredibly elevated lipase, pain. And this is one of the top GI reasons for hospitalization in the US. It costs a lot of money, as you can see there, and the incidence is rising. So this is the approach. Of course, like with anything, you want to try to establish the diagnosis, but then you want to try to determine the etiology so that you can hopefully try to prevent any future attacks of acute pancreatitis, assess the severity, treat. Now, I'm an advanced endoscopist, and it's so frustrating to me that even in 2022, really all we have to treat acute pancreatitis is still IV fluids. And we'll talk about this more in a bit, how much, but it's moderately aggressive. And then another point, which I think people don't appreciate as well, is that you need to reassess these patients frequently, especially during the first 24 hours after admission. It's not you just set them on fluids and then you forget about them until the next day. You need to assess them. I'll talk about this as well. Early nutrition, important. Use the gut preferentially early. And then finally, refer to a pancreatic center like we have at the Brigham for patients with idiopathic pancreatitis or severe pancreatitis. All right, so let's start off by talking about diagnosing acute pancreatitis. We still talk about the revised Atlanta classification led by Peter Banks over a decade ago now. And it talks about having 2 out of 3 criteria in order to make a diagnosis. So elevated abnormal labs, which nowadays we mainly use lipase, and it needs to be at least 3 times the upper limit of normal. So just a few points above the upper limit of normal is not considered abnormal or consistent with acute pancreatitis. It needs to be at least 3 times. And of course, pain, which typically is upper abdominal pain that's severe, may or may not radiate to the back, and then finally imaging. The single best imaging to do is really ultrasound, and this is assuming you've already made a diagnosis of acute pancreatitis, and now we're trying to look for etiology. So when is a CT helpful? Well, if you're not sure that the patient has acute pancreatitis, absolutely get a CT scan. Or if they're not getting better after the first 48 to 72 hours, again, get a CT to see if there's some complication occurring, necrosis starting to develop, et cetera. And if they have signs of severe pancreatitis or local complications. So in terms of now that you've made a diagnosis, you want to try to figure out why the patient has acute pancreatitis. And gallstones is the leading reason still in the US, followed by alcohol. And I put in there 1, 2, 3, 4, 5 glasses of wine a day because that's the kind of the amount of alcohol someone should be drinking in order to then eventually potentially develop acute pancreatitis. So it's not just 1 glass of wine a day. And of course, the amount of alcohol is different with different types of alcohol. Now, this is interesting, which I still like to talk about, is this randomized trial of patients with alcoholic pancreatitis. They randomize patients to either 2 30-minute counseling sessions. So one that was done when they were hospitalized and the second that was done 6 months later, versus just 1 alcohol cessation counseling session while they were an inpatient. And you can see there pretty, effective, dramatic difference between the ones who had the 2 counseling sessions on recurrent acute pancreatitis. So ideally, your patients who have this as a result of alcohol, you should be trying to get them into counseling in at least just 2 sessions. All right, smoking is another underappreciated etiology of acute pancreatitis. This is a study from Gut from a little while ago, and they talk about the relative risk of developing non-gallstone pancreatitis with current smoking, patients who have at least 20-pack year history of smoking, and then if you smoke and drink, and now here drinking was about 1 glass of wine per day, but if you did both, you see much higher risk of getting non-gallstone acute pancreatitis. Other etiology, if the patients swear they don't drink alcohol or smoke and there's no gallstones or sludge. Metabolic reasons, of course, we always think about triglyceride, typically over 1,000, although more recently, there's been some data to suggest that even over 500. Hypercalcemia as well. So this is why calcium and triglycerides should be checked on all of your patients. And then for patients over the age of 40, which seems awfully young to me, but if they do not have an obvious reason for acute pancreatitis, you should be thinking about pancreatic mass and make sure you get good imaging to exclude the presence of a pancreatic mass. And of course, congenital anomalies like pancreas divisum, annular pancreas, choledochal cyst, not as common. Autoimmune pancreatitis, I put there IgG4, although the type that patients get in the US usually are IgG4 negative, but that's another thing to think about. And of course, genetic etiologies, which we usually think about in younger patients, and you should send off genetic panels in them. ERCP, we mentioned a variety of drugs, infection, trauma as well, and then of course acute flare-up of chronic pancreatitis. So the initial work of course, history, targeted history, and then labs, as I mentioned, LFTs, calcium, triglyceride, ideally at presentation, not a day into their hospitalization, and then ultrasound. All right, so now let's move on. So we've talked about diagnosing, trying to figure out the etiology. Let's move on and talk about how to determine the severity because this correlates with mortality. And thankfully, the overwhelming majority of acute pancreatitis are mild, and about 10 to 15% of cases are considered severe. And you can see there the mortality rate much higher with the severe patients. And this is how we define severity. So those who are considered severe, it is defined as having persistent organ failure that goes on for at least 48 hours, or of course, death. Moderately severe are folks with transient organ failure that lasts less than 40 hours. So let's say, for example, somebody's creatinine bumps up, you give them more hydration, and then it normalizes within 48 hours. That would be considered moderately severe acute pancreatitis. And then, of course, patients with local complications, meaning fluid collections, necrosis, they're considered moderately severe. Now, defining organ failure, you can use the modified Marshall score, and having 2 or greater in any system is considered organ failure. You can see there for renal, it's pretty easy. It just goes based on the creatinine. Cardiac, also pretty easy based on the systolic blood pressure, whether or not they're fluid responsive, and then the pH. The respiratory, a little bit more complicated because you have to do some calculation there. Now, how can we predict those who are going to get organ failure? Emission hematocrit that's elevated, at least 44, and a rising BUN within the first 24 hours are 2 predictors, reliable predictors of organ failure. And this is also one of the reasons why you want to be assessing these patients within that first 24-hour period. Now, I think we all know about the various criteria to predict mortality in acute pancreatitis. And my problem is, even with apps and computer and whatnot, it's just such a pain for me to try to remember this. I have a very bad memory, but I can remember BUN. So if you can remember one thing, remember BUN. And you can see here why. A BUN that's 20 or greater at admission, 4.6 odds ratio of mortality. Similarly, if the BUN is going up by at least 2 points within 24 hours, bad odds ratio for mortality again. So that's why paying attention to BUN is so important in these patients. And these are some additional risk factors for severe acute pancreatitis from the recently updated acute pancreatitis guideline published in the American Journal of Gastroenterology. patients over the age of 55, obesity, altered mental status, presence of stirs and pleural effusions and/or pulmonary infiltrates. Now, on the other hand, is there a way to predict patients who will do well? And there is what we call the HAP score, the harmless acute pancreatitis score, that is defined by having normal hematocrit, normal creatinine, and no abdominal guarding and/or rebound. Very, very high positive predictive value for predicting patients who will do well and won't develop complications from their acute pancreatitis. All right, so back to our case. 53-year-old female admitted with acute pancreatitis, had elevated LFT. She's on room air. This is her admission B1 of 12 and hematocrit of 35. So therefore, mild pancreatitis with low risk of mortality. Now, I'm going to talk about some terminology because we talk about these when you consult us on GI. And there's two broad categories of acute pancreatitis, interstitial or necrotizing. And then the patients can have acute or mature collection. So acute, in the interstitial pancreatitis patients, we call that acute peripancreatic fluid collection. About 20 to 40% of patients develop that. And then if you fast forward about 4 to 6 weeks, those acute collections will mature and form a pseudocyst. This happens in about 10% of patients with acute peripancreatic fluid collection. So really small minority of patients with interstitial pancreatitis. On the other hand, patients with necrotizing pancreatitis really, almost by definition, have acute necrotic collection in the beginning. And then again, you fast forward about 4 to 6 weeks, and the acute necrotic collection forms what we call this walled off pancreatic necrosis. And about 50% of patients with acute necrotic collection will develop walled off pancreatic necrosis. And of course, at any time, patients can get infections. So this is an example of acute pancreatitis, acute interstitial pancreatitis. I want you guys to think of which CT is demonstrating acute interstitial pancreatitis. One of them shows that, the other one is normal. And hopefully you guys were all thinking that the CT on the right is consistent with acute interstitial pancreatitis. And the way that you can tell is looking at the fat around the pancreas, which kind of looks lobular and feathery. And you see how the fat around it is very gray. There's fat stranding as opposed to the clean fat on the left side where you don't see any of that. Now, this shows you acute pancreatic, peripancreatic fluid collection. And if you, again, focus on the pancreas there behind the stomach that has oral contrast in it, you see some sliver of fluid around the neck and around the tail. And then I'm going to scroll down a little. You see more and more of this kind of dark fluid encasing the pancreas. And then magically, you fast forward about a month ahead, all that amorphous fluid coalesces into what we call a pseudocyst. You should not call somebody who has necrotizing pancreatitis and has something like this having a pseudocyst, because it's not a pseudocyst. This is just simple fluid and no necrotic debris in there. So moving on to necrotizing pancreatitis, acute necrotic collection. If you again focus on the pancreas right in front of the aorta there, you see in the middle, the pancreas looks dark. So that's dead pancreas tissue. You can almost imagine dead pancreas tissue kind of being vomited out into the retroperitoneal space there. And again, magically, you fast forward about a month, and it all coalesces to this walled off pancreatic necrotic collection. All right, now in terms of management, as I said earlier, it's IV fluids. It should be lactated ringer because Beach and Wu, who was one of my former colleagues at the Brigham, he published his seminal randomized control study comparing lactated ringer to normal saline and showed that there was significant decrease in SIRS, and other studies since then have shown decrease in severity of pancreatitis as well. Now, how much? It's what we call so-called goal-directed IV fluid. And this is from another very important randomized trial, published in the New England Journal a couple years ago, so-called waterfall trial, that randomized patients with mild acute pancreatitis to aggressive versus more conservative fluid. And the aggressive was they gave patients a 20 cc per kilogram bolus followed by 3 cc per kilogram per hour infusion, versus the other group where it's 10 cc per kilogram bolus if hypovolemic, and then 1.5 cc per kilogram per hour infusion. And by goal-directed, they reassess these patients and within that 24-hour period. And upon reassessment, if the clinician's assessment was that the patient appeared hypovolemic, they repeated the bolus. Normal volemic, they either turned down the rate from 3 to 1.5 or just kept the rate at 1.5 cc per kilogram per hour. And if they thought the patients were volume overloaded, they either decreased or stopped the fluid infusion. And what you see at the bottom table is their finding, which is that the aggressive IV fluid arm, those patients, there was no significant difference in the rates at which they developed moderate to severe acute pancreatitis compared to the moderate IV fluid group. But the problem was that significantly more patients who were in the aggressive IV fluid arm developed fluid overload. And some of these patients need to be intubated, et cetera. So this is where our goal-directed IV fluid recommendation comes from now. What is the goal? The goal is to decrease BUN. So remember, as I said, if you just remember one thing from this talk, remember BUN. That is your goal. And so you want to sign out to recheck key labs within that first 24-hour period, BUN and hematocrit. And depending on what they're doing, adjust the fluids accordingly. So if the BUN is going up, then you might need to bolus or increase the rate, et cetera. So back to our lady with the diabetes, gallstone pancreatitis. The emission labs, again, looked pretty benign. 12 hours later, though, her BUN had gone up to 20 and her hematocrit's up to 39. So what is the next step? Well, all we got is fluids. So we bolused her with an extra liter of LR. And then again, you don't just, set it and forget it. Then we rechecked the hematocrit and BUN 6 hours later to see what was happening. Thankfully, her hematocrit had come down to 35 and her BUN had come down from 20 to 14. All right, so let's move on and talk about, I know people's favorite topic, pain. I don't have a lot of great things to say about pain management. Of course, if you're able to get away with non-opioids like NSAID and tramadol, that's great, but typically these patients end up needing narcotics. Now, with nutrition, the key point here is you want to start them within 24 hours. And multiple studies have shown that early oral or enteral feeding within that first 24 to 40-hour period decreases the need for intervention for necrosis. And also there's been a trend towards decreased infection and organ failure as well. And the other thing I want to point out is you don't need to start patients on clear liquids. You can start them on a low fat. It's debatable if it needs to be low fat, but I know a lot of us like to do low fat. Soft or normal diet. Now, if the patients cannot eat, either because they're intubated or feeling nauseous or something, then you can just drop an NG tube. That is much better than TPN. So drop an NG tube and start them on tube feeds. And the presence of fluid collections or elevated enzymes is not a contraindication to starting patients on nutrition. All right, antibiotics. Do not use them unless you need to. So do not give prophylactic antibiotics. It just increases issues with resistance and fungal infection. Of course, if you think the patients have cholangitis, infected necrosis, infected pseudocyst, or if they're decompensating, give them antibiotics. If there's a concern for infection, you can consider CT-guided aspiration before antibiotics if it's possible, but it's unclear whether CT-guided aspiration is necessary in alters management. Now, a word about abdominal compartment syndrome, which is that it's bad when it happens in acute pancreatitis. The definition here is elevated intra-abdominal pressure over 20 with new onset organ failure. As you can see there, in acute pancreatitis, high mortality rate. You should think about measuring this in patients with severe pancreatitis with organ failure, and certainly patients who have a very tense, distended abdomen. We typically use bladder pressure with bladder catheter. You can put NG tube and rectal tube into these patients to try to manage this and optimize their sedation and analgesia. Consider muscle relaxants, consider diuretics. I know we talked about fluids as treatment, so diuretic sounds a little contrary, but you can certainly consider that. Early nutrition we talked about, maybe even percutaneous drainage of fluid if it's really bad. When we talk to our surgeons, they do not like taking these patients to the operating room because their mortality is so high. And so they, rather than the absolute number, they like to look at the trend. Even if the absolute number is high, if it's stable, they typically won't take these patients to the OR. And there was a study on neostigmine. You can consider using that if no contraindication. Okay, so now the timing of cholecystectomy in patients with mild gallstone pancreatitis. When should they have it? And they should have it before they get discharged. Multiple studies have looked at this. This is one randomized trial that compared patients with, again, mild acute gallstone pancreatitis who either had same emission cholecystectomy or were discharged and then had so-called interval cholecystectomy, which is about a month after discharge. And you can see here significant difference in their primary endpoint, which was mortality or readmission for gallstone-related complications, as well as you might expect significant decrease in recurrent pancreatitis, and patients reporting colic during the waiting period, but no significant difference just in mortality. So please consult your surgeons and have them take the patient's gallbladder out before they get discharged. If the patients can't have a cholecystectomy, we can certainly do ERCP with biliary sphincterotomy because that is protective against future biliary events, although not as protective, of course, as having the gallbladder removed. Now, the role of ERCP in acute gallstone pancreatitis, there's not a lot. If you think the patient has cholangitis or if they have documented CBD stone, or postoperatively, if the surgeons on intraoperative cholangiogram saw a CBD stone, those certainly we should do the ERCP within about 72 hours. It's not indicated for severe gallstone pancreatitis. There was a randomized study in Lancet a few years back where they randomized these patients to urgent ERCP versus conservative management, by urgent meaning within 24 hours of admission, and noted there was no difference in complications or mortality. All right, so let's finish up with case number 4, which is a 54-year-old male who has necrotizing gallstone pancreatitis that started about 5 weeks ago, transiently intubated, but now is on the floor with abdominal pain and cannot eat. I actually showed you the CT earlier, and it's pretty obvious why he can't eat. He has a humongous walled-off necrotic collection that's squishing his stomach thin like a pancake. You see that little bit of contrast in that squished stomach there. What are the options? As with many things, there's surgery, radiology, and endoscopy. And if your hospital does not have access to any of these, then you should transfer these patients to a center with the above expertise. Now, a word about conservative management for infected walled-off necrosis. It is possible, which when I was an intern, was anathema. All these patients had to go to the operating room and then they all ended up dying. But now this is a prospective observational study of patients, again, with infected necrosis who are asymptomatic. And you see there are 30 patients in this study, and they follow these patients on the antibiotics. And you see there 22 of the 30 did fine. And in fact, about 2/3 of those patients, the collection got smaller. And in the rest, there was no change. Now, in this study, 8 of the 30 did develop some symptoms that required intervention, but nobody needed surgery. There was no mortality. So this is certainly reasonable to think about and do in patients who are stable. Now, when we talk about endoscopic drainage or necrosectomy versus surgical management, there's been multiple randomized studies comparing the two modalities. And the main difference, the main reason endoscopy is preferred, as with many things, is that there's decreased morbidity. Mortality rate does not seem to be significantly different, but approach leads to fewer complications. And this is what we do. So this is the older way that we used to do it before these special lumen-opposing metal stents came available. In the upper left image, you see the stomach and you see this compression, extrinsic compression from walled-off necrotic collection that you see on the EUS image to the right. And then in that fluoroscopic image, you see contrast has been injected to define that cavity. You see a balloon that's been inflated across from the stomach into the cavity. And then the upper right image, you see that balloon. So we're creating a new opening into the walled-off necrotic cavity. And the bottom left image shows you what it may look like once you enter the cavity with a scope. You see that's dead pancreatic debris there. And then the one to the right shows after it's been cleaned up, then we need to leave stents behind to keep the cavity draining into the stomach. Otherwise, it'll close off and become an abscess. And then this was about a month afterwards, the lower right CAT scan image, you see that collection gone. So it works very well. And the summary of kind of results is that when we do endoscopic necrosectomy, there's about 70-90% success rate, 20 to 40% complications and up to 6% mortality rate. For endoscopic cyst gastrostomy, which is what we do for pseudocysts. For pseudocysts, remember, it's just a fluid collection. So it's literally just like popping a zit and all the fluid just pours on out. We don't need to go out and debride any necrotic debris because there's, by definition, no necrotic debris. As you can see, they're highly successful with much lower complications. This is a quick video. You see, there's an EUS image of a walled-off necrotic cavity. The black is fluid, and then you see some of that bright stuff in the lower left, bottom, lower right. That represents some debris in this collection. I'm going to play this video that just shows you. So I'm going in with our lumen-opposing metal stent. The inner phalange has been deployed there. And then in the bottom, and here we go. And then this is the endoscopic image showing the other flange. And that is usually the way we do these procedures now. So the decision points when you're confronted with walled-off necrotic collection or pseudocysts is, are symptoms present? Because if the patient does not have any symptoms, you don't need to intervene. However, they should be followed in a pancreatic center. And then if the patients do have symptoms, and the next question is that necrotic collection, fluid collection mature, which usually takes about 4 weeks to occur. And if the collection is mature, then we say endoscopic necrosectomy or drainage is the methodology of choice. If the collection is not mature and there's no nicely formed wall around it, then it's really radiology is the only choice, percutaneous drainage. And then surgery as backup if everything else fails. Again, as a reminder for patients with infected necrosis, conservative management with antibiotics is certainly reasonable if the patients are stable until the wall matures. And then, then we can certainly do endoscopic drainage. But if the patient really are doing well, you can even just continue to manage them on antibiotics. But again, needs to be followed at the pancreatic center. All right, so here are some take-home points. To try to determine if the patient has CBD stones, you can certainly use the ASGE guidelines there. And if you determine that the patient has intermediate probability for having polydocylithiasis, then you can either send it for EUS. The advantage of EUS is that if we see stones on EUS, we can immediately do the ERCP in the same session. But of course, if EUS is not readily available, MRCP is fantastic. And intraophthalmography if your surgeons are willing and able to do that. Cholecystectomy after after ERCP for CBD stones should be done. And moving on to cholangitis, emergent ERCP that's defined as happening within 24 hours should be done for patients with severe cholangitis. And you can use a Tokyo guideline, not only to try to diagnose cholangitis, but also assess the severity. Now, early ERCP defined as occurring within 72 hours, should be done in acute gallstone pancreatitis only if you think the patient has cholangitis or retained CBD stone. And when you're dealing with acute pancreatitis, you want to try to determine the etiology. Again, treatment is just fluids, but remember it's lactated ringer and modest fluid in the first 24 hours. But again, in the first 24 hours, you want to recheck their BUN and hematocrit and tailor the fluids as appropriate. Oral or enteral feeding should be begun really immediately within the first 24 to 48 hours of the patients being admitted. Use antibiotics very sparingly in acute pancreatitis. Think about monitoring bladder pressure in your severe pancreatitis patients, and certainly those with very tense, distended abdomens. And for the patients with mild gallstone pancreatitis, please consult your surgeon so that the patients can have their gallbladders removed before leaving the hospital. And then you certainly need a multidisciplinary approach with referral to a pancreatic center for severe or idiopathic pancreatitis. We have a multidisciplinary conference at the Brigham every Friday, which is a fantastic conference with our surgeons, radiologists, sometimes pathologists, and certainly gastroenterologists, where we talk about these very complicated patients. So thank you so much for your attention, and I'm happy to take any questions if we have time for some.
Excellent, Dr. Lee. We do have some questions, and we have a bit of time. The most popular question here from the group is, I believe, kind of getting at sometimes hearing different recommendations on who needs an MRCP before they have an ERCP done. If you feel like they are a patient with cholangitis who is at high risk, or someone that you may do a little sooner. And could you explain some of the differences there? I think you touched on it with the surgeons and how comfortable the surgery team might be with an intra-op cholangiogram, but could you touch on that a little bit, what the MRCP is getting you as an endoscopist beforehand?
So if you're specifically asking about in the setting of cholangitis, right? Mm-hmm. So I think that it depends is my honest answer. So if somebody you suspect has cholangitis, if their bilirubin is like 6, and let's say they've had an abdominal ultrasound and the CBD is dilated, if it's like 7-8 millimeters, then I don't feel like that particular patient needs an MRCP necessarily before an ERCP, because then they supposedly meet that high risk for choledocholithiasis criteria from the AHG guideline, right? But if it's not that, if somebody does not meet those criteria, then I would want an MRCP to see what that shows. If they do see sludge or stones in the bile duct. And the other confusing thing, which I didn't really touch upon in this talk, but the other thing that can be confusing is sometimes, is it really cholangitis or cholecystitis, right? That's another issue that comes up. And and so that's where, again, maybe MRCP may be helpful in helping us to sway us one way or the other. Is it cholecystitis or is it really cholangitis? So really, I'm looking for an MRCP if I'm not sure, based on the clinical laboratory criteria presented to me, that the patient really has a CBD stone that requires my intervention. Because the problem with ERCP is that it's not a benign procedure. We like to think, oh yeah, no problem, do an ERCP. Well, it isn't benign. We can give them pancreatitis, right? Despite rectal indocin, despite pancreatic duct stenting, we can still give them pancreatitis, which can be bad. And the number one reason for getting sued for ERCP related cases is because of lack of indication, appropriate indication. So that's why we're very kind of conscious about that. So that'd be the main reason. Okay.
We talked about GLP-1s in a few talks so far in the course, one from the perspective of obesity medicine. And I think a lot of us have seen patients with either gallstone or non-gallstone pancreatitis who happen to be on a GLP-1. What is your take on, your recommendations when you see patients like that? They don't have another clear cause for pancreatitis, and kind of continuing or holding the medication at discharge?
Oh, that's a tough question.
I know,
And
sorry.
no, it's a good question, but I'm not sure I have the right answer.
Okay,
I think that, obviously nowadays it's ubiquitous. It's like you might as well just put it in the water nowadays, right? But I honestly, I think again, that just depends, right? Because it's always very difficult to figure out if it's medication induced acute pancreatitis, like with many things, right? And
right.
so I think you really, in that situation, I would recommend getting a gastroenterologist or a pancreas expert involved, kind of comb through and see if there's any other etiology. And if the patients are having recurrent acute pancreatitis and you have nothing left but that, then I think you do have to hold it and see what happens to the patient. Obviously, if you hold it, they get acute pancreatitis again, well then, okay,
Yeah.
that wasn't it. And then you can put them back on it. But yeah.
Okay. Okay. And then you had mentioned excluding pancreatic masses in patients with, what we feel is like maybe idiopathic, or we don't know the reason for the pancreatitis in patients over 40. Do you have any guidelines around imaging? Like, should it be done after the acute episode? How long do you usually, recommend that we wait? And which image is ideal for that?
Oh, excellent questions. And there's no guideline-based recommendation, so this is just my personal bias.
Hmm.
I would do the imaging while they're hospitalized because,
Okay.
I just don't want to lose track of these people, right? And oftentimes a radiologist can tell if there's a
Hmm.
mass there versus just inflammation from acute pancreatitis. So I would do it while they're captive audience in the hospital. What imaging study would I recommend? I prefer MRI of the pancreas because
Hmm.
it is superior to CT for picking up small masses and things like that. If that's not readily available, pancreatic protocol CT is just fine as well.
Okay. Excellent. And I think our last question for you is about enteral feeding in patients with pancreatitis and whether or not NG or NJ or jejunal feeding is needed. What's your take on that?
Great question as well. These are all fantastic questions. And I really appreciate them. So, yes, in the older days, we used to think we
Hmm.
had to do feeding beyond the ampulla because we don't want to stimulate the pancreas. So, I remember those horrible days where, we were consulted to put nasojejunal tubes down. I'm like, oh my gosh, these are miserable procedures. All GI people hate doing these. But there have been kind of multiple studies, not great randomized controlled trial data, but multiple studies that have confirmed that doing tube feed through an NG tube does not worsen the person's outcome or, cause recurrent, bouts of pancreatitis in patients with acute pancreatitis. So this is actually in the revised updated guideline from the ACG that NG tube is just fine. So please don't consult your gastroenterologist, put down
Okay.
NJ tubes. You can just put an NG tube down at the bedside and get them started on tube feeds. But of course, there's only in patients who can't eat, right? I mean, if they
Right.
can eat, then please just have them eat.
Excellent. That's perfect. Thank you so much. Great answers to those questions. Great talk as always. We are going to take a break for lunch or an extended break. Switching gears a little bit with some dermatology starting at 1:30. So thank you again, Dr. Lee.